Welcome back, everybody. Today, we're going to be diving into something that I'm sure you guys face all the time as neurologists,
Yeah.
is how to best manage anticoagulation
Right.
in patients that have had an ischemic stroke
Yeah.
while they're already on a DOAC. So we're going to be unpacking some of the latest research and figuring out how we can apply it to your practice.
Okay.
So our source material today is a recent meta-analysis
All right.
that was published in the International Journal of Stroke
Okay.
that pulled data from 6 studies
Mm-hmm.
with over 12,000 patients.
Wow.
They looked at 4 strategies for managing these cases:
Mm-hmm.
staying on the same DOAC,
Right.
switching to a different one,
Yeah.
adjusting the dosage, or going back to warfarin.
Okay.
And you might be surprised to hear that the simplest approach
Okay.
seems to be the most effective.
That is fascinating, isn't it?
Yeah.
DOACs have really changed the game when it comes to preventing strokes for patients with non-valvular atrial fibrillation.
Right.
Studies show they're incredibly effective,
Good.
reducing the risk of stroke by a huge 66%.
Yeah.
But even with DOACs, some patients still have a stroke.
Right.
Somewhere between like 0.7% and 2.3%.
Yeah.
But that's in the studies, and in real-world settings, it could be even higher.
Yeah, that's a good point.
So how do we adjust treatment when a stroke does occur in a patient already on a DOAC?
Exactly. So we're really trying to manage that residual risk,
Mm-hmm.
but it's a balancing act.
Right.
So this meta-analysis gives us some good data to work with.
Okay.
Over 12,000 patients.
Yeah.
And they measured some key outcomes.
Right.
Like ischemic stroke recurrence,
Okay.
intracranial hemorrhage,
Uh-huh.
other bleeding events, and even mortality.
Wow. So they looked at everything across all 4 management strategies.
Yeah.
And what surprised me the most was that maintaining the same DOAC regimen actually resulted in the best outcomes across the board,
Interesting.
especially when compared to switching to warfarin.
So give us the numbers.
Yeah.
How much better did staying the course really perform?
Right. Well, the data is pretty compelling.
Okay.
Patients who stayed on the same DOAC had a 45% lower risk of having another ischemic stroke compared to those who switched to warfarin.
Well, that's a big difference.
It is a significant reduction.
Yeah.
And it gets even better.
Okay.
They also had a 63% lower risk of intracranial hemorrhage
Oh, wow.
and a 56% lower risk of any kind of bleeding event.
That's amazing.
Yeah,
Those are some serious advantages to just sticking with the original DOAC.
it is.
But I remember you mentioned something interesting in the data.
Oh, yeah.
What was that about?
You're right. The meta-analysis found an association with an increased mortality rate.
Interesting.
It found a hazard ratio of 1.85 for
Huh.
patients staying on the same DOAC.
Huh.
But the data on mortality varied quite a bit across the studies in the meta-analysis.
Okay.
So we need to look at this finding carefully.
Yeah, for sure. More research is needed to clarify that.
Absolutely.
But focusing on the more positive side of things,
Right.
what about the other strategies? Like switching to a different DOAC or adjusting the dose? Did those show any benefit over sticking with the initial DOAC?
Surprisingly, no.
Really?
Neither switching to a different DOAC or adjusting the dose was better than just staying the course.
Huh. It really makes you rethink those initial impulses, doesn't it?
It does.
Like you always think you need to change something up
Right.
when a patient on a DOAC has a stroke.
Yeah, it seems intuitive,
Yeah,
but the data doesn't support it.
it really doesn't. So if DOACs are showing this clear advantage, why might warfarin be underperforming in these situations? What are your thoughts on that?
That's a great question.
Huh.
I think we need to consider a couple of things.
Okay.
First, how DOACs and warfarin work differently pharmacologically.
Okay.
And second, all the different things that could be going on with individual patients.
Right. And those things might not be fully captured in these big observational studies.
Exactly. It's complex.
So let's break that down. First, pharmacologically, how are DOACs different from warfarin in ways that could be affecting these outcomes?
So with warfarin, it inhibits the synthesis of vitamin K-dependent clotting factors.
Right.
But DOACs, they directly target specific clotting factors.
Okay.
Like dabigatran directly inhibits thrombin,
Mm-hmm.
while rivaroxaban, apixaban, and edoxaban target factor ZAZ.
Okay.
So this more targeted mechanism of action
Yeah.
might be why they're better at preventing recurrent strokes in patients who've already had one while on a DOAC.
That makes sense. I mean, targeting specific factors that are involved in clot formation
Right.
would probably be more efficient than just a broader approach.
Exactly.
But you also mentioned patient-specific factors.
Yes.
What kind of things are we talking about?
Well, there are a lot of things that could influence these outcomes.
Right.
And these might not be fully accounted for in large observational studies like this one.
Okay.
For example, adherence to medication is a big one.
Oh, yeah, for sure. If a patient isn't taking their medication as prescribed,
Right.
it won't matter which anticoagulant they're on.
Ex-
Yeah, we can't underestimate the impact of real-world adherence on treatment effectiveness.
No, we can't.
What else should we consider?
Drug interactions are another really important thing to think about.
Okay.
DOACs can interact with a lot of other medications,
Right?
which could make them less effective or increase the risk of bleeding.
Yeah, that's a good point.
So when a patient on a DOAC has a stroke,
Mm-hmm.
it's essential to carefully review their medication list and make sure there aren't any potential interactions.
So it's kind of like detective work.
Yeah.
You're looking for these hidden clues
Right.
that could be impacting how well their DOAC is working.
Exactly. And we also need to make sure that the stroke was actually related to atrial fibrillation.
Oh, right.
Maybe there's another reason for the stroke.
Like what?
Could be a large vessel stenosis or a small vessel disease.
Okay.
We need to make sure we're treating the right problem.
That's really important. We need to investigate all those other possibilities.
Yes.
Before we make any decisions about changing their anticoagulation management.
I agree.
So before we even think about changing a patient's DOAC or switching them to warfarin,
Mm-hmm.
what are the essential steps you recommend taking?
Well, first you have to really look at each patient individually.
Okay.
Prioritize those patient-specific considerations.
Okay, so what does that look like?
First things first, you got to make sure the patient is taking their DOAC as prescribed.
Great.
Evaluate their adherence.
So are they actually taking their medication?
Right. And if they're not,
Yeah.
can we figure out why and fix it?
Right. So are there any challenges or barriers to adherence that we can try to help them with?
Exactly. Sometimes simple things can make a big difference,
Like what?
like pill organizers or medication reminders.
Yeah, those are good ideas.
It's about getting the basics right.
Right. You want to optimize those things
Exactly.
before you assume that the medication itself is the problem.
Exactly. The next step is to check for any potential drug interactions. Go through all their medications carefully.
So that includes over-the-counter medication.
Yes.
And herbal supplements.
Everything. And if you find an interaction,
Yeah.
think about whether you can adjust the dose or choose a different DOAC
Okay.
to minimize the risk.
So essentially, you're trying to find a workable solution without completely abandoning the DOAC.
Exactly. And of course, ruling out non-atrial fibrillation-related causes for the stroke is super important.
Right. So we might need additional imaging studies,
Yeah.
like a carotid ultrasound or an MRI,
Mm-hmm.
to check for other possible causes.
You got it. It's about looking at the whole patient and their individual situation.
That makes a lot of sense.
Yeah.
So really taking a holistic view.
Exactly. And, there are some interesting studies going on right now
Oh, yeah.
that are looking at some new interventions
Okay.
for patients who have a stroke while on a DOAC.
That's exciting. So which studies are you talking about?
There's Intercept and ELAX.
Okay. I've heard of those.
Oh.
What exactly are they looking at?
Intercept is looking at the potential benefits of adding bilateral carotid filters to the treatment
No.
for these patients.
So how would that work?
The idea is that these filters could trap any clots
Okay.
that are traveling from the heart to the brain,
Interesting.
giving them an extra layer of protection.
So it's like a safety net
Yeah,
in case the DOAC isn't enough on its own.
exactly. And then there's ELAP-PC,
Okay.
which is focusing on left atrial appendage closure.
What is that?
It's a minimally invasive procedure
Okay.
that basically seals off a little pouch in the heart
Okay.
called the left atrial appendage.
And why is that important?
Well, this pouch is a common place where clots form
Oh, I see.
in patients with atrial fibrillation.
So these clots can then travel to the brain and cause a stroke.
Exactly.
So these are two very different approaches,
They are.
but both aimed at reducing that leftover stroke risk.
That's right.
What are your thoughts on how these trials could change things?
If they show positive results, I think they could really change how we manage these complex cases.
How so?
Imagine being able to offer a procedure
Yeah.
that could lower the risk of stroke even more,
Right.
even in patients who are already on a DOAC that's working well.
It would be huge.
It would be a big step forward.
It really would.
Yeah.
It'll be interesting to see what the data shows.
I agree.
Okay, so let's talk about what all of this means for us in practice.
Okay.
What did these findings tell us about how we should talk to our patients?
Well, I think it highlights how important it is to be upfront with our patients.
Okay.
Be transparent and really communicate openly with them.
About what?
We need to explain that there's still a small chance of stroke,
Right.
even with the best treatments.
Yeah, even if they do everything right.
Exactly. And if
Yeah.
they do have a stroke,
Yeah.
It doesn't necessarily mean that the medication has failed.
That's a good point.
We have to manage their expectations
Right.
and make sure they really understand
Yeah.
how complicated stroke prevention is.
It's not always straightforward. And it underscores the importance of patient adherence,
Definitely.
lifestyle changes,
Yes,
and regular follow-up appointments.
absolutely. We need to empower our patients
Yeah.
to take an active role in their own care.
I like that.
Mm-hmm.
So it's all about working together,
It is.
doctor and patient as a team,
Absolutely.
a collaborative approach.
To get the best possible outcome for the patient.
Exactly.
So it seems like we're really changing how we think about stroke prevention in these patients.
Yeah, it's a real shift.
Instead of automatically switching medications or adjusting the dose,
Right.
we need to pause and look at each patient as an individual.
Exactly. Yeah.
Individualized care.
And I think this is where neurologists can really make a difference.
How so?
We can advocate for better support systems for our patients.
Yeah, I agree.
We've talked about how important adherence is,
Mm-hmm.
but how can we actually help our patients with that?
Well, we can make sure they have access to things like adherence programs
Okay.
and medication management services,
Hmm.
and even educational materials.
So giving them the tools and information they need.
Exactly. Even simple things can help,
Like what?
like clear instructions on how to take their medication.
Right.
Simple but important.
And we can also advocate for changes at a system level.
What do you mean?
Things like policies that make medications more affordable
Oh, yeah, that's huge.
and easier to get.
Because those things can be big barriers to adherence.
Exactly. High drug costs and insurance issues can make it really tough for patients to stay on track.
Absolutely. And we also need more research,
Yes, definitely.
so we can better understand the long-term effects of DOACs
Mm,
and develop even better ways to prevent strokes.
I agree.
Well, it's clear that there's a lot more to learn
There is.
and so much we can do to help our patients who are at risk for stroke.
It's an ongoing process.
So if we had to boil it all down, what's the biggest takeaway from this deep dive?
Well, I think the most surprising thing
Yeah,
is how effective it is to just stay with the initial DOAC,
okay.
at least based on what we know now. So staying the course is actually the best approach,
It seems that way.
even though it feels counterintuitive.
It does.
Like you'd think you'd need to change something
I know.
when a patient has a stroke on a DOAC.
You'd think so, but this meta-analysis shows us that we need to really understand the individual patient
Mm-hmm.
and think carefully before making any changes to their treatment plan.
And as a final thought for everyone listening,
Yeah.
think about all those real-world challenges we discussed,
Okay.
like adherence, drug interactions,
Right.
and other possible causes of stroke.
Mm-hmm.
How can you use these insights in your own practice
Yeah, that's a good question.
to really optimize stroke prevention for your patients?
Every patient is different.
Exactly. And what can you do to advocate for better support systems
Yeah.
so your patients can get the most out of their DOACs?
That's what it's all about.
But this has been a fascinating look at DOACs and stroke recurrence.
It has.
We've only scratched the surface here.
Right. There's so much more to explore.
So I encourage everyone to check out the full meta-analysis
Definitely.
in the International Journal of Stroke
It's a great resource.
and get all the details. Thanks for joining us today,
It was a pleasure.
and we'll see you next time for another deep dive into the latest neurological research.